One thing I forgot to do in the last video is kind of score as we go. Off of this example, I have 4 descriptors. So what I'm going to do, normally I'll circle this if I have the paper format, but since I don't, I'm just going to highlight it here. Okay, now let's go ahead and talk about review of systems. The reason that you'll recall from the last video I skipped associated signs and symptoms is because they're very closely related to review of systems. Now, associated sign and symptom for a descriptor is only one element, and it has to be a positive thing. So let me show you an example here of what a physician is going through here. She's feeling lightheaded and faint. I could use faint as an associated sign and symptom. I chose not to, so that way I could use it as a review of systems. A review of system is any positive or negative, and there can be multiple. What we do is we count systems, but physicians typically, and they should do this, is record them as aspects. So what does that mean? So right down here, you see that this particular physician has said no vomiting or diarrhea. That's important for other physicians to know. But for our purposes, they're both part of gastrointestinal system. So on this worksheet, you've got GI right here, and they're both negative, right? So that counts as 1 review of systems, even though she's done 2 aspects. She said no vomiting, no diarrhea. It's 2 aspects of a single system. The one that I commonly see is no fever, no chills. Those are both part of constitutional, even though they're 2 aspects, and they should be documented that way. Technically, physicians do get credit if they say something like musculoskeletal, negative. I don't like that because it's not a very good communication. What was negative? Do they have any joint pain? Or is there any muscle weakness that we didn't find? What exactly that you asked the patient did we find out? So when you go through a note to look for any review of systems, you want to look for things that are complaint related. So as an example, I've got faint. Now faint could be a constitutional, it could also be a neuro, it could also be cardiovascular. It really depends on what the whole context of the note is. For this case, I'm going to count it as cardiovascular since we're looking at lightheadedness. Passing large clots, since we're talking about this patient's period, then that's going to be GU, genitourinary. Feeling tired is constitutional. This is history right here. Blood transfusion. Social history, she's sexually active. Trying to lose weight, eating 1 to 2 meals per day. I could count this more as a context descriptor, but she's not actually said that there's any weight loss. No fevers, which is also constitutional, but we already counted it with feeling tired. Nauseous is gastrointestinal. Thirsty, I would say, is constitutional. Vomiting, diarrhea is also gastrointestinal, but we already did that. Headache is actually neuro. It is not musculoskeletal. Not urinating more than usual is also GU, but we also got that with this large clots. So we've got 1, 2, 3, 4, 5 systems that have been reviewed. Okay, we've got constitutional, we've got cardio, gastrointestinal, genitourinary, and neurological. I should have put these under the negatives. I put them under the positives. I apologize for that. So we've got 5. Okay, when looking at review of systems, it's this column right here. There are 4 possibilities. There's 0, 1, 2 to 9, 10 or more. Alright? For our patient here, we've got 2 to 9. So I'm going to mark that real quick. I want to say a note about this 10 plus. There is a phrase that some physicians use called all other systems reviewed in negative. Technically, they do get credit for all of these systems. Now, sometimes I will intentionally not count that, because if they come in for like a URI and it says that all other systems were reviewed, there's no indication of medical necessity to do that. So it's more of a compliance move on my part. Some physicians have a habit of using that phrase, and if you find a physician who does that, do your best to get them out of that habit, because it will put them at a legal risk. It does up the code a bit, and it's just not worth it to try to have that little bit of a higher element per se, and usually it really doesn't do much for a good code. Okay, so that's review of systems. Also notice something here, because I'm going to reference it later about higher and lower, but for all of these, the lower is actually towards the top and the higher is towards the bottom. That'll come into play especially as we get at the end. Okay, let's talk a minute about history. Remember how we talked about aspects of review of systems, and we talked about the actual systems, so it's aspects versus systems. With your history, your past medical, family, and social history, it's the same thing. There are aspects to past medical history, but you only get 1 point for mentioning anything about past medical history. You only get credit for mentioning one. You could mention all 5 of them, but you still only get credit for one. Some of the things that are in past medical history are as follows: medication list, allergies, problem list, past surgeries, accidents. Those are the big 5 that you'll see in past medical history. If they review the med list and the allergy list, which they should always do, it's just good medicine, then they get 1 point. Okay? If they don't, but they say, patient is a current smoker, current smoker is part of the social history, so they get 1 point for the social history. So I'm trying to give you an idea of how these different aspects of the histories relate to the histories themselves. So the best way to learn is to do it by example. Okay, she's not on any current medications, she doesn't have any current allergies. This is all past medical. It says here that she has a family history of diabetes in the paternal grandparent. So, probably the paternal grandpa. Sometimes you'll catch the history. So she has a daughter. That's also social history. So we've actually got all 3, and we've got smoker up here. She's never smoked. So now we've got three histories. Okay. Here the possibilities are 0, 1, or right here there's 2 in there. You can't see them very well. Let me see if I can blow it up a little bit. Page width 100%. Nope. I think I want to do page width. We'll do 200%. Okay. See right here where it says 2E, 3N. What that means is that in order to get to this upper bucket, you need 2 for an established patient and 3 for a new patient. For this week and next week and the week after, this week and next week, we're going to assume they're all established patients. So we have all 3, but all that tells us is that we're in this bucket right here. So I'm going to highlight that. Okay, I'm going to try and do one last thing here. No, it's not going to let me do it. Okay. So you can see here that we've got 4 more descriptors, we've got 2 to 9 review systems, and we've got 3 histories mentioned in the note, in my example note here. One thing I should mention, the things that show up in social history are smoking status, recreational drug use, alcohol consumption, marital status, employment status, number of children, seatbelt usage, educational status, anything that's socioeconomic. Family history is any mention of a disease related to another family member. So those ones, the possibilities are a lot greater. Past medical only has 5. Social history I think has about 14, and I've never counted family history just because it's so variable. Going back to determining what level of history we have, there are 4 possibilities. There's problem focus, expanded problem focus, detailed, and comprehensive. Problem focus is the smallest. It's the least in point value, the lowest. Comprehensive is the highest. Okay, you can see these grid marks right here. The rule is that the lowest guy wins. Now, you can't really see it real well here, but this is a blue dotted line. This is just something that Word does. If I were to print it down here, it wouldn't be here. This is just one section. Okay, so in order to get comprehensive, I would have to have 4 or more descriptors or 3 C-note. I would have to have 10 plus review of systems, and I would have to have, for an established patient, 2 out of the 3 histories. For a new patient, I'd have to have all 3. Okay, that would be the minimum. For a here though, I don't have 10 plus review systems. I've got 2 to 9 review systems. Now the way that this grid works, and all these subsequent grids, which we'll go over the next couple weeks, the lowest guy wins. So whatever bucket is lower here, which corresponds to these boxes in this column, that's the level it is. So the lowest one that we've got here is the detailed, because it matches up with this 2 to 9. Okay, so this note is detailed. If it were only 1 review system, it would be EPF, because it relates to the 1 review system. If they didn't mention anything about history, this might be a little bit more difficult to see, but it would relate to EPF, because the 0 covers both the EPF and the HPI, or the PF and the EPF, problem focused and expanded problem focused. Same here with the descriptors. If there's 0 to 3, then it would be an EPF, assuming that there wasn't 0 review systems. The only way you could get a problem focused history is if there's 0 to 3 descriptors, no review systems, and no history. That's the only way you can get problem focused. And then comprehensive takes these 3 highest ones. The rest of the combination will be between expanded problem focused and detailed. Most of the time it should be detailed. I would say that that's a good quality note, as if it's detailed. If it's not detailed and it's an expanded problem focus, it depends on the patient and what they're presenting with, but I always try to get physicians to shoot for that detailed history. It's good documentation. Okay, so that's an overview of the HPI this week. Your assignments are in the assignment page, where you're going to go through 5 notes. So you got plenty of time to go through it, and I want you to try to find the descriptors, the review of systems, and the past medical, family, and social history. Now the difficulty with these assignments is that coding is a lot about interpretation. So you may find something that I didn't. I tried to minimize that so that way there's a clear right and wrong answer, but keep in mind that when you get out into practice, it's not that way. It really could be different answers, and people interpret it differently. So if you see something that I don't be afraid to bring it up. If you can back up your answer, I will honor it. I think that's good for you to know, because the same thing's going to happen with an insurance audit. If somebody audits you and you can stand behind your answer, you need to have the freedom and the ability to stand up and say, no, you're wrong. This is where I got it, and this is why.